Hi everyone, welcome back to my channel. My name is Yana. I'm one of the nursing students at Sunshine Coast University in Queensland. If you have been watching me for a while, you know that I'm graduating this year, hopefully in December, to become RN. And I've done also Diploma of EN at TAFE. That's why you will see some of the videos that I've been doing before and still doing as a sort of like a recap. They would be about TAFE studies and also about uni studies for Bachelor of Nursing Science. So in today's video I will be sharing with you my experience of going into neurosurgical ward. For the privacy reasons, I'm not going to be mentioning the hospital I went to, but I will tell you what I've been doing during this placement. Okay, for those of you who've never been on a placement, I'll just briefly tell you that during your placement you may have your days from Monday to Friday only and then have a weekend off, or you may have your placement, like for example doing Monday to Thursday or to Wednesday, have a day or two off and then coming back again on a weekend. You also may be rotating from morning to afternoon shifts, so depending on a hospital, your mornings may start from 6:30 or 7 or 7:30 and then finish 2 o'clock, 2:30 or 3 o'clock. At some hospitals, like private hospitals, you might finish at 3:30. Okay, you will start your shift with receiving handover and finishing your shift by giving handover to the upcoming shift. Your PM shifts or your afternoon shifts, they may start from 2 o'clock, 2:30 or 3 o'clock PM and then finishing at 10:30, 11, or if it's a private hospital at 11:30. Again, private hospital to private hospital is different, so it depends where you go. So get ready to leave your shift sometimes really late, and if you are placed somewhere an hour drive from your home, just get ready to come home really late, okay, and get ready for the next shift. For me, luckily enough, in this placement I had only Monday to Friday and each week was just one shift time. So I had 1 week AMs, the next week PMs, and then rotating again. So I had time to recover sort of like and rest on the weekends, spend some time with my kids and things like that. Okay, so in this ward, this was a neurosurgical ward. So as the name says, it involves your brain, your spine and your nerves that attach to your spine. Okay, and my advice to you, if you know that you go into this ward, usually you will know like 2 weeks or 3 weeks before you go. Please revise your anatomy. Just review all the materials for your brain anatomy, your physiology of the brain, you know, just see the names of the lobes that you have in your brain, just see all the layers, you know, see information and how your ventricles work. Also research about your CSF fluid, how the nerves transmissions going through your brain and through your spinal cord, and how they transmit all the signals through the body and how they receive the signals and all of that, just to give you sort of like a reminder sort of, you know, and the review to all these systems. Because when you will be going through this placement, you will need to understand where the surgery was done, on which lobe of the brain, of the skull, you know, and if you do your research and revision of the anatomy of what each lobe is responsible for in terms of functions in your body, you will know that if the person, let's say, had an injury to a front lobe, okay, your frontal lobe, just this area here, this plate of the skull, this may affect your motor, your thinking, your analogical skills, somehow memory as well, even though this part would be more responsible for memory, you know, and things like that. So this will sort of like give you indication if you see sort of like certain symptoms in your patient after the surgery, you know, if they had a really big trauma to this part of the skull or to the brain, you may notice certain, like, I wouldn't call disabilities, but certain like decline in functions in their systems or in their body. So again, it will give you sort of like more insight of what's happening to your patient, like in a bigger picture, you know what I mean? So yeah, if you have time to do that, definitely I would advise you revise all your anatomy things. Now I want to go with you through the things that I've done during this placement. I have this messy sort of like piece of paper with notes that I usually do, because I find that some things I do forget, because once I finish my placement in a particular ward, I don't go there back again to practice. It's not a place of my work where I would be going there all the time and keeping things in mind, you know, remembering things. So once we as students completed the placement, we may forget things, you know, and because we're moving on to different subjects in a uni, we're getting ready for the next placement, whatever it's going to be, and things like that. So I always put notes for myself, and because I run my channel, I'm trying to help you guys as well and give you insights of what I'm going through as a student. It's easier for me to keep a track on if I follow my notes. Okay, so in this ward, it would be the same as to any other ward in terms of medications. You will still have your medications morning rounds when you need to give medication to your patients before breakfast time. So you would generally start at least an hour earlier before breakfast comes, because some of the medications could be harsh on the stomach, on an empty stomach, and would be preferable to give it with food. Also, you have to keep in mind that you have like, it's 2 nurses, 2 of you, and you may have 8 to 9 patients to look after. You know, some of them may have infusions like IVs, some of them may have subcuts of anticoagulants in the morning, like your heparin, Klaxane, and all of that. So that needs time, especially IVs. You need a second check, you need to prepare the IV, you know, and things like that, mix the medication, you know. Some of the people may have NG tubes and need to administer the medication through the NG tube. So that involves a lot of time. So you need to start your preparation for medication at least an hour earlier. Then you will have some medication given like Panadols and things like that closer to 12 o'clock. And then you will have some medications given at 2 o'clock. It could be as well some Panadols and things like that. Some of the people may have quite a lot of medication by 12 o'clock, you know, or 2 o'clock. It depends what they are on, but the major one would be your morning medication round, okay, if you're doing morning shift. 4 p.m. shifts or afternoon shifts, your biggest one I would say would be at 8 o'clock, when you need to give a lot of medication, very similar to the amount that you would do in the morning just before they go to bed. In between, you may have some medications at 5 o'clock or 6 o'clock, like your Panadols as well, you know, and things like that. And then you will have some of them at 9 o'clock, okay? You may have someone being diabetic. You will need to do a BGL check before they go to sleep. And if they are on a slight scale for insulin, you may administer insulin at evening as well. Like that would be like closer to their bedtime. Then you will have a lot of patients with tracheostomy, okay? But in this hospital, as RN students, although we are grad students and we have to practice like pretty much everything now, because this is our last chance to practice now before we go into a free world of being alone basically, and getting our registration. So, but for this hospital, we were not allowed to do a trachea suctioning. That was done for the safety reasons. We could only watch the body RN doing it, but we could help them to change the dressing on the trachea, but not the actual suctioning, okay? So yeah, so I wasn't able to practice that. Even though it's in our scope of practice as RN student, we were still, for safety reasons, asked not to do it, which was a little bit pity, but it's okay. I mean, like, safety always comes first for the patients, so that's the main goal. Then you will have, as I mentioned before, a lot of patients have an NG. So this is your nasogastrial tube, okay? And here you as RN student can practice, and you are allowed to practice with your body RN nurse under supervision, insertion and removal of NG tube if it needs to be changed. When it could be changed, like for example, some of the people who are elderly and have dementia, they may pull it out. Some of the people who had really dramatic brain injuries and it affected their cognition may sometimes pull it out as well. So in this case, you will need to reinsert it again, okay? So they have in this hospital a printed out policy how to do it. So you can speak to your body RN nurse or to your facilitator. Most of the hospitals would have it anyway. You can print it out and it shows you what equipment to prepare, all the steps, you know, to follow. And easy peasy, like seriously guys, it's not that hard at all. The whole procedure takes like about 5 to 10 minutes, and if you do it correctly it can even take less than that. Okay, so if you want I can make a separate video on that and just in theory explain to you how I've done it, because I have the print out policy and I can go through the policy with you guys and just maybe help you to get your head around it. You know, I won't be able to show you of course how to do it like in person, you know, but yeah, I can tell you in details because I've done quite a few, and I believe I can help you. Okay, so we can do it in my other video. Also, if someone has an NG tube, that person won't have anything through the mouth, so that would be all the feeds would go through that tube, your medication would go through the tube and things like that. So if the person would be on feeds, they have a feed chart, okay, and in that feed chart it tells you whether the person is on continuous feeds from 6 o'clock in the morning till 10 o'clock, and it will tell you what type of feeds they receive, what's the amount of feeds. Usually it's like it's a nutritious mix, looks like a smoothie. It will have different brand names in it. It has all the nutrients, vitamins, minerals and things like that that your body would need to gain from normal food, like fruits and veggies and grains and all of that, but that all is already blended into sort of like a smoothie consistency, and it usually comes in bottles or the packs of 200 milligrams. Okay, so you will run that through the pump, so you will attach this bottle upside down, attach to the pump, and you will put the rate, okay, and the person will have that. Obviously if someone is on continuous feeds, you will need to change the bottles every time the bottle is finished. The rate would be slower. Some people would be on feeds like every few hours, okay, and it will tell you again the name of the feed mixture and then the amount, how many meals. Okay, then at the bottom of the chart, I wish I could find it for you to show you, but if I find it on the internet I'll try to put the picture here. If I won't, I'm sorry guys, it would be probably not easy to find it, but at the bottom of that chart you will have indication of how many meals you should flush before administering feeds, like when you just start, and then if you give medication, even if the feeds are still running, you have to stop the feeds, do the flush, and then give the medication and then do another flush. The reason why you would give another flush after medication, even though if the feeds are still running, just because in the portal where you open to insert the medication through the syringe, the top of it may have a build-up of medication that you give into the patient. So if you can imagine you're given a few times a day, it can build up quite a dose there, you know what I mean? So it's always better to flush it with water just to keep the portal always clean. So at the bottom of the chart you will find that the person would have, it's written actually by the doctor, the person would have like 30 meals flush before and after, so 30 each time, or it may be 40 or 60. Some people would be on a fluid restriction, so they would have a little bit less flush, but I had patients who had 40 meals, 30 meals and 60 meals flush. So what you would do is, if the person has a continuous feeds running through the pump, you will stop the pump, you would give a flush of just the normal water according to the amount of the meals for that particular patient in the chart. Then you would crush the medication in a crusher, add a little bit of water to it. I usually add about 20 to 30 mils of water, mix it good, take it into a syringe, you know, and then push it through, and then give another flush of whatever meals is written in a order. Let's say if it's 30, so you give 30 before, push the medication, and then give a flush again through the syringe, through the same syringe. Then you need to wash the crusher and you need to clean the syringe. Okay, the syringe can be multi-used again for another few times, so like I would suggest to use a syringe once a shift and then change another one. Okay, but it's up to you. Like I always clean it, just keep it clean, and then you resume the feeds again. Okay, also what I do as well, when I stop the feeds, I like to clamp the, you know, the part of the tube that goes into feeding bottle to the pump. I like to just clamp it or like append it with my fingers, so when I give medication it wouldn't go like to the pump, but it go down through the actual tube down to the stomach and stuff like that. But it's up to you. But this is the practice that the other nurses taught me, and I'm just keep doing it all the time, which makes sense to me. So that's for NG tubes. A lot of people will have IDCs, as in any surgical ward, which is quite normal. Sometimes when they come from the surgery post-op, they wouldn't be just getting out of the bed easily like that. But because it's a neurosurgical ward, remember that severity of your traumas to your brain for each patient could be different, okay? Some of them wouldn't be even getting out of bed at all for quite a long time. Okay, so in this case, they would have IDCs. For those who have IDCs temporarily, just for some time, you know, your doctor may come and after they review the patient post-op. By the way, when someone come post-op, whether they come from ICU, if they've been critical, been sent to the ICU after surgery, then been sent to us, or they've been just in the PACU in the recovery room and sent to us, they technically are still critical patients. In this case, before the doctor come and review them, we have to do OBS, which includes your vital signs and your neuro OBS every 2 hours until the doctor reviewed the patient. Or if the patient came for example, from PACU and they stayed there in the recovery, let's say only a short period of time, but the vitals were stable and they send it to us, the person could be on half an hourly OBS or could be 4 hourly OBS. Okay, so half an hourly OBS, they go for 2 hours, hourly OBS go for 4 hours, then 2 hourly go for another 4 hours, and then they go like 4 hourly or 6 hourly, depending on their condition. Okay, but still the doctor needs to come and review the patient. So sometimes the doctor may come and say, okay, I'm happy for the IDC to be removed, and just see if the person can try pass a trial of void, like basically trying to go to toilet and do a wee. But for the order to be more like legal, the doctor has to write it in a patient chart, but not the patient chart, the blue one that they have near the bed. The patient chart, like all the history of the medication and conditions and stuff like this, you know, your big yellow folder that usually in the nursing station, they have to actually write it in a progress notes section. You as a nurse, when you go and check and you find that the order has been written for IDC to be removed, only then you remove the IDC, because sometimes the doctors may tell you, okay, I'm happy for you to remove it, but they didn't write it yet. The hour passed or 2 hours passed, you went and you checked and nothing is written, the doctor got busy or disappeared somewhere because they have so many patients to look after. Feel free to catch the doctor whenever you see them and just say, hey, you said for this and this patient the IDC should be removed, you still didn't put it in the nursing progress note, can you please do it so I could do and remove it, you know? And they're happy to do it. They're really friendly, really polite, and really cool to work with. So yeah, so you only remove the IDC once you see that the order is written there. And once you remove the IDC, just tell the patient that when you feel like going to toilet to do a wee, please buzz me, I will come and help you, you know, and you know, assist you when you go to toilet. Just make sure that they are steady on their feet when they go. So what I usually do for someone who is getting off the bed first time, you know, I set the person up on a bed, let them sit for maybe like a half a minute or a minute on the edge of the bed, then stand up, march on the spot a little bit, just see if the person is feeling lightheaded or nauseous or things like that, you know. And if it's safe to go, then I assist the person to go, you know. Sometimes people might not walk and you need to use like a Surgeries or something like that, so the physio can review the patient and tell you more information on that. But when they went to toilet, okay, if it's a male, you can give a bottle to the man and see how much they pass of urine. If it's a female, you can put a pen in there and just see if the amount of urine is quite sufficient, like if it's a good amount that they pass, like the output. And then once they finish in the toilet, they go back to bed and you do a bladder scan and see if there is any amount is retained inside. If the amount is like 20, 30, 50 mils, it's okay. And you see how much the pass is good enough, cool. Some of the hospitals and some of the nurses would say, okay, one time trial of void is good, like the person passed enough of urine, not much retained inside, they pass the first trial of void and it's cool. Some of the hospital will go like 3 passes, like you need to have 3 passes, so see how much been put in the toilet, you know, how much retained inside, and after 3 times, if it's all good, continuously after each time, the person is good to go and IDC doesn't need to go back in again. Again, depending on the nurses and depending on the hospital, everyone just practice a little bit different, but you generally see how much the person went, like what was the amount and how much is retained. if you've done a first scanner and you can see that inside is retained like 200, 300 or 400, I would not pass a person from the first time. I would prompt the person to go to toilet again and then repeat the whole procedure, just see how much was the output and see how much is retained inside. If I see that retention inside is much less, it becomes like 100 or 50, I may go a third time just to make sure. If I see that the amount is quite big or it stays the same, like 300 or 400, that's a little bit of concern for me there. So in this case, you can either like if your body RN with you, obviously when you do the scans and stuff like that, they can see, you can either report to the doctor or you can wait and do the third trial and see how they go, you know. But generally, if the person is still retaining a big amount inside, doctor may actually order for the IDC to go back in again and stay in for a while and then do a trial for it later on again. If go back to the anatomy, you know how your brain is controlling different systems and functions of your body. Sometimes if something being affected in a certain area of your brain, it can affect how your bladder work, how your heart work, how your liver work, how your cognition work, how your motor responses work. So like you can't expect a lot from people who had brain injuries, you know, because they have this sort of like, I don't want to call it disabilities, but I would call it malfunctions in their bodies, you know, that is connected to the injuries that they have, you know. So yeah, so you have to be mindful of that. Also, you will have a lot of patients that will have TADs and SCADs. So those ones are the pumping machines attached to your legs, to your calves. So if you ever been in a hospital yourself, if you had the surgeries or anything like that, you probably had those ones attached to your legs. It has this good sensation when it's pumping, you know. Sometimes I want to have this ones when I come from work, you know, just lay down in my bed and someone can attach it to my legs because my legs are aching by the end of the shift from walking and standing too much. But in hospitals we put those ones to the patients to prevent DVTs, that's formation of the clots in the veins of your legs and traveling up to your lungs or to your brain or to your heart. So this is very important. If someone is not getting out of the bed, not moving their legs often, those machines, you know, or devices could be very, very helpful. Next, I just want to mention something about PRN doses. Okay, this is very important, especially if you work in a really past environment ward when everyone and everything is just rushing through the shift. If someone is complaining of pain, and you will have a lot of post-op patients complain of pain, of course, because they had surgeries, everything is hurting, so you have to manage the pain level quite efficient. So you will give PRN quite often. Just make sure that before you administer another dose of PRN, if your patient is complaining still of pain, have a look when the last dose of a particular medication has been given and what was the dose. For example, for endones, you may have doses from, I'm just giving an example now because they're all different. You may have doses starting, like says for example 5 milligrams to 10 milligrams, okay, every 3 hours. You may have some of the patients having different levels of pain and the nurses may decide to start only by giving 5 milligrams. Then they may reassess the patient and see if the pain has resolved. If not, they may give additional 5 milligrams because the dose says from 5 to 10. 10 would be max, and it has to be given in a time frame of 3 hours. So if you've given the patient already all 10 milligrams, you can't give another 5 or 10 until the time frame is over. So in this case, if the patient is still experiencing the pain, you can have a look if the doctor has written any other pain relief in a PRN section. If not, you can go to the doctor and speak to them and see that, okay, this dose has been given, the patient is suffering from pain still, can you write something else? And they can write other type of opioids. If you come on a shift and your patient, for example, been given a PRN by the nurse before you and the patient is still complaining of pain, do not just rush by giving quickly PRN. Always pay attention. If, for example, you're looking at endone, when was the last time it's given? What was the maximum dose given? Can I still give this one or I can't? If I can't, what are my other options down the list. Sorry guys, my camera turned off again. So yeah, if you give, for example, endone, just make sure that you still keep that frame in between the doses, especially if you work in a past environment where everyone and everything is rushing. You know, you don't want to overdose your patients something, especially on something like opioids, because it can affect your respiration rate, your heart rate, you know, can keep you and make you really drowsy. So you have to be making sure that you always pay attention to that. Okay, and yeah, if your patient need any other pain relief that is not written in PRN section, you know, and they really need it right now because you can't give any other pain relief because it's been already given, you can go to the doctor, you know, and talk to them and see if they can write something else. Okay, and you as a nursing student have to practice talking to doctors, because this will be your job when you become fully licensed RN. You need to liaise with the doctors, you need to talk to other multidisciplinary team members, you know, and discuss the concerns of your patients, because in the end of the day, the nurses are the closest points to the patients and will look after them from the morning until evening, and we know and we see what they need better than anyone else, because we're literally staying with them all the time. Okay, so you're an advocate for your patient, and yeah, if they have any concerns, if they need anything, you have to make sure that all of that is resolved during your shift. Then you will have a lot of med calls. I initiated a med call myself for one of the patients that had seizures, so I needed to press the button because it was reoccurring seizures, and in the end the person was sent to the surgery to relieve the pressure because he had a bleed, internal bleed. So yeah, in this case you will have your blue team coming, you will have your ICU nurses coming, you know, and yeah, it's quite intense. So the whole emergency team will come and try to resuscitate the patient, you know, stabilize the patient, things like that. Then they may send them for MRI or CT scan to see what's going on in their brain, you know, if there is a bleed, swelling, you know, and things like that, you know, and take a further action there. So sometimes as a nursing student you may step aside and just let the team work, obviously, because this is very important, very fast everything happening, you know, when they try to save the person. So if you initiated a med call, just step aside somewhere and let the professionals do their work. You are welcome to watch if you want, but just try to give them space, you know, and stand somewhere on the side. The second med call I had was one of my patients as well, but it wasn't me who initiated, it was my body nurse. The other time I initiated the call because my body nurse was on a break and I went on a break before her, so I needed to take an action. Second time my body nurse was with me on the floor, and yeah, so she initiated the call for the patient because the patient had some cognitive difficulties. He had quite severe brain injury and he literally just pulled out his trachea. And trachea is a vital device in your body, you know, to give you oxygen, and if you pull it out, he literally like just got all purple and blue in color, and this is very serious situation, because the person may die, because your lungs, your heart, your brain, nothing is receiving oxygen anymore. So we needed to initiate a med call right away, and the ICU team came, code blue came, trachea nurses came, you know, and put the trachea back, you know, stabilize the patient. So for this situation I needed to be a person who would be writing and doing the vital signs every 5 minutes on a patient while the emergency team working on stabilizing him. So I needed to do the vital signs and do the BGL and just check all of that every 5 minutes and write it down, you know. And then this piece of I forgot what was the form for it, the name of the form. So this is happening during the emergency procedures like that, during the med call. Then you take the whole thing, and you will be doing this like maybe for 20 minutes every 5 minutes or 30 minutes, depends how long the whole situation goes for, until the patient becomes stable. And then this piece of paper or this form, you take it out of this big folder that you're writing in, like they have a lot of blank forms like that. Once you fill it in, you put the sticker of this patient, you took the whole form, fold it, and put it into yellow chart of the patient, their yellow folder, okay, and it stays there as a history, you know, of him having a med-con. So yeah, that was quite interesting. It was really nerve-breaking for me to just stand there and record all of that and check the vital signs every 5 minutes, while the other like more serious and advanced professionals working and running around me and stuff like that. But in the end of the day, I was happy to take that part as well, because once you become a nurse, licensed nurse, it will be your responsibility to take part in it as well, because if it's your patient, you know, who else would be doing it for you? Because the other specialists come, they work on more important areas for that patient, you know, to survive. So something like data recording would be the least easiest to what they do, so you as a nurse can do that as well. If they ask you to give them a help as well, give them a hand, you can do that as well, you know. But yeah, it's quite interesting, but it's very nerve-breaking. Like, I'll tell you, you would feel really nervous, especially when it comes to someone else's life. So yeah. Then you will have a lot of MRI and CT scans. So most of your patients will be once or twice sent to dose, pre-op or post-op, just to make sure there is no swelling or pressure or bleeding and things like that. You will have a lot of IVs for antibiotics, IVs, infusion that could be done through the burette or bolus. So push, you just do the push through the cannula. Okay, remember, when you do your IVs, you always do it with your RN, and I suggest to you, because you as a student do not know how to mix each and every antibiotic or any other type of medication, use the injectable yellow drug book that every nursing station has in pretty much every hospital. They have MEMS, they have Harvard, so that one for your medication classes and indications. And the drug injectable book is this is one is how to use your drugs for injections, okay, or infusions and stuff like that. So find the name of your drug, see the route, whether it's can be like on the med chart, of course it will say whether it can be IV or oral, whatever. So if it's IV, you go to this book and you see, can it be given as infusion, or can it be given through the burette, can it be given through the IV, through the bolus push, you know, which fluid you would mix with. Is it a glucose, is it normal saline, or is it water, and things like that. So you just see how you mix it, and then the duration, how long you will be infusing it for. So this book is very, very helpful. I'll try to put a picture for you here how it looks like, and as I said, you will find in most of the nursing stations, and your body RNs and your facilitators will love you for using it, because that just shows that you are a very safe student and you care about your patients. Okay, so that is for that. You will have not a lot of patients, but you will have patients who would be diabetic. So some of them would be on a standard BGL checks, which means 4 times a day. Some of them would be on an insulin scale, so you will need to give them subcuts to their tummies of insulin. Some would be on an insulin infusion. Then in this case you need to be checking, as the policies and procedures of the hospital say, hourly BGLs. You may have few patients who would have PCA analgesia. There's just a button that they click for opioid to be administered every 5 minutes when they're in like quite bad pain and things like that. In this ward I only had like one patient on one of the shifts of mine who had PCA. So in this case you have to just record the intake, how much the patient pressed the button and how much been administered, because it doesn't matter if you press the button every minute. It has pre-set up doses that go like, let's say, every 5 minutes. So if you have a lot of pain and you press in every minute, that's just the indication to us nurses when you take the readings that the patient is still in pain. Okay, so you can give something as PRN on top of the PCA as well. Okay, that just gives us indication that the patient's still pressing the button because they have a lot of pain. Okay, but the generally pump won't give you every minute every time you press. It gives you like every 5 minutes or whatever it's been set up or programmed for. Then you will have a lot of Evd drains. This is your internal ventricular drain. So if to go back to the anatomy of the brain, you have your ventricles in your brain, which is positioned just in the center of your brain, just like from the back in the center there. These ventricles are filled with CSF fluid, which is your cerebrospinal fluid. And this fluid goes in the ventricles inside, then it goes all around your brain, and then it goes down to your spinal cord and surrounds the spinal cord as well. And then it's changing and distributing through the bloodstream. This fluid is always running and always changing. For the brain, it just serves as a caution to just keep your brain, I don't know how to explain. It surrounds it all around it, and then it goes into ventricles as well. So your brain is like swimming in it. So if you have a heat to your head, you know, or anything like that, firstly it will protect a little bit, you know, so it won't heat on the skull walls, because it has this beautiful cushion of this fluid around it, you know what I mean? And also it brings the nutrients, you know, and everything it needs to the tissues of the brain as well. So this fluid is really important. So for some of the people, this fluid, like if they have hemorrhage, you know, internal bleeding, you know, or the swelling of the ventricles, you know, or some other trauma or lesions, you know, tumors and stuff like that, you know, they have like a lot of this fluids build up in there, and some of the functions of the body may disrupt this fluid to be draining down your spine and distributing to your body. So it will start to accumulate in your ventricles, you know, or in other areas of your brain, and just giving more pressure to your brain. So in this case, to relieve this pressure, you know, the doctors may do a procedure when they insert a Evd drain to your ventricles. It goes down like here through your brain, you know, I mean like through your skull and brain and down to your ventricles. I'll try to put the picture for you here to show you how it looks like, you know, and it would be draining externally to the drainage device outside. So you will see the person will have this drain coming out to the device. Then this device would be attached to the centimeter scale. I'll try to put the picture for you here to make you understand how it looks like. Only the doctor can set up how many centimeters the mark goes. Does it go to plus or to the minus? Because if you drain a lot of CSF fluid, the ventricles may collapse and include the catheter. If you don't drain enough, then the fluid will be still accumulating in your ventricle, causing it swelling, inflammation, creating more pressure, which can lead to seizures, to drowsiness, and all sorts of problems for the person. So only the doctor can decide and adjust the centimeters of how much the fluid needs to be drained, okay? And then beside it, it will have a laser torch, or whatever you call it, like a laser light. So this is what we do as nurses. So if we try to move the patient on a bed, sit them up, take them to toilet, do their cares and stuff like that, lay them flat when we do the cares, you know, then we need to clamp the EVD. Then we do all the cares for the patients. Once we've done, we will sit the patient up. Like if I have someone who has EVD, I would always tend to keep the person at least like 35 or 45 degrees up, just sit in position. And then before you unclamp, you have to take this laser light and point it just here in this area. Okay, it has to always point here. This is how it works with the centimeters that the doctor put and the light. If the light is not pointing there and the patient is lying down, you unclamp the thing, you might drain too much of fluid from the patient, okay? So make sure always that the light goes there and then you unclamp it. Okay, so that's for your EVD. The fluid, CSF fluid, could be clear, could be darkish a little bit, could have even blood. That means just the person has blood in the ventricles a little bit, maybe from the hemorrhage or whatever the problems or trauma they had, you know. So everyone will be different, you know. And then as a nurse, you will need to write down the amount of CSF fluid draining every hour and CSF drainage chart. You have to write it every single hour how much has been drained. If you see that the person suddenly stopped draining fluid, like for an hour or 2 or 3, you have to report it to the doctor. In this case, the doctor may change the centimeters, you know, maybe lower the whole thing a little bit down and see maybe the drain got blocked somewhere, you know. They may keep it like that for a few hours to see if it can resolve itself. I had a few patients who had it blocked and then it resolved itself. If it doesn't, then they may send person to surgery, so to operating theater, so they could redo it, you know. And yeah, I had a patient who's been sent to the surgery 3 times because every time her EVD would get blocked. It was really hard, but yeah, it is what it is. Then you will need to do a lot of neurological observations. So get yourself ready, get yourself familiar before you go on displacement, revise your neurological observation assessment, see all the steps. Yeah, so in this ward you will need to do it literally with every vital signs taken. Okay, you will need to do that, neuro-obs. What you always notice that a lot of doctors and nurses would speak in abbreviations. Like for example, in Glasgow Coma Scale they would say like E2, V4, M6. So E stands for your eyes, then V for voice, and M for motor. So when they say like I'm just going to open it on my phone so I could show you the same pictures that I will be looking at. Hopefully I saved it somewhere. Okay, so when we talk about E2, for example, that means that the eyes were opening to painful stimuli. So that means when you do your neuro-obs, you go to the room and it's like, hello Michael, how are you? Let's say if the patient name is Michael, and Michael is not reacting, like he's not opening his eyes to your speech. For example, you're greeting him or asking him something. You may come and do the trapezius squeeze, or you may take a pen and just push on a nail bed a little bit and see if the person is opening their eyes and reacting to it, or maybe withdrawing the hand or something like that. So if the eyes are open to the painful stimuli, that would be your E2. Okay. If it's V4, so when you go to voice section, 4 would be confused. So you would ask your patient, can I have your full name? And they should tell you their full name. Then you can say, do you know where you are? You know, and they may say, I'm in a hospital such and such, or they may say, no, I'm at home, you know. So that shows that the person is confused. Or they may give you wrong date, or wrong day of the week, or year we live in, or month, you know, and things like that. So that would mean that the person is confused. So sometimes they would answer some of the questions right, sometimes they would answer some of the questions wrong. You know, I usually, if the person gave me full name correctly, place where they are correctly, but they are not aware what date it is, what day of the week, or the year we live in, that would be confused. I would put confused. Then M6, so M is for motor and 6 would be obeys commands. So you would ask your patient to squeeze your hands. So you put your hands in their hands and ask them to squeeze, and in this case you would just also check the power of the strength of the squeezing, and also the difference between 2 hands, okay, which one squeezes less or more, or if it's equal. Then you ask them to lift their arms up, and you push here and ask them to lift it up against the pressure. You do the same for the fingers. You ask them to flex their fingers up, and you push here like that and ask them to raise it up against your pressure. Same for the legs. Raise each leg, push the push the toes towards your nose, bring them towards your nose, push it down, and check the strength in both legs. If they do all of that, that would be M6, which means obeying commands. Your facilitator won't ask you to go by this sort of way, abbreviations, when you give a handover, but try to get your hand around it, because this is how nurses will be talking, this is how doctors will be talking between each other. Okay, they will be just going E, V, M, this number. Okay, with time of practice you will know that 6 means obeying commands, 2 means E2 means, you know, opening eyes to painful stimuli, you know, things like that. So you will start to remember things, because as you can see on the picture here, each section doesn't have many parts in it. It's only like few, so it's not that much. But yeah, just try get your head around it. And obviously see what's your GCS score. You know, when your patient, what number is identifying that the patient is in a critical situation, just pay attention to that. You know, just go through the form itself, through the whole observation chart, read all the parts in it and see, you know, how it works, you know, what it means and things like that. So very important on this ward. Also, you will have a lot of people on dexamethasone. This is a type of medication which is steroid medication to relieve swelling in the brain, especially for those who've been post-op. Okay, so you will find a lot of people are on dex, and they will start for quite big doses, and then the doctors will try to wean them from this dose by decreasing the dose and the amount that they give during the daytime until they completely wean the person to 0. Okay, so if someone is on dex, you will need to do a BGL at least once a day. Okay, or once a shift. So because steroids can raise your BGL levels up, so you have to monitor that. Also, when you give your patients anti-hypertensive medication like Ramipril, Atenolol and others, just always pay attention what was the systolic pressure of the person in a previous vital signs or OBS chart. And also, if you see that the person been quite low in systolic, if the last systolic was measured, let's say an hour ago, you might think if it's been like 90, 98, you know, 100, because some people have blood pressure naturally low. Some people don't drink enough of fluids, which keep their blood pressure low as well. So you just make sure that you do not give antihypertensive if someone already has a low systolic blood pressure, because what antihypertensive medication do, they lower it more. So that's their purpose. This is how they work. So if you give to someone who already has a low blood pressure another hypertensive medication, their blood pressure even drop even more. This can create more falls if the patient needs to go to toilet or get up for food and stuff like that. That's a worse work for the for the heart as well, because it has to pump efficiently if it has a good blood pressure and things like that. That just creates more drowsiness to the person and things like that. So you just need to make sure that you always check the blood pressure, especially as well for the elderly people. Okay. So that's for that. So anytime when you see medications like Ramipril, Atenolol or Prn in your medical chart, always have a look at the OBS. What was the systolic blood pressure? Okay, going back again to EVDs, sorry, something I forgot to tell you. You as RN student won't be allowed to touch it. Only, so now there are two things that you won't be touching: trachees, suctioning, you can't do it, and EVDs. Okay, you can't clamp it, you can't adjust the razor light, you can't do anything about it. Like, only your RN body can deal with EVD, you can't. Okay, so there are two things you won't be able to do it as RN student in this ward. Some of the people who have cognitive functions declined, or someone who's having decline in cognitive function and dementia on top of that, could be on restraint. So for the restraints, this is very serious matter. It has to be therefore ordered by the doctor, and the order has to be always renewed. Okay, you only restrain someone if there is a valid order for it. Restraints could go 2 points, which are your arms only, or 4 points, which are your arms and your legs tied into the bed. I know it doesn't sound and might look in your imagination a little bit scary and weird, and maybe remind you a little bit about maybe mental facilities when people, you know, have mental disorders and stuff. But for someone whose cognitive functions being altered, for their safety, we like the doctors, they may restrain them, because, for example, if someone has a trachea, if someone has an NG tube, if someone has IV important drugs running, if someone has a fixation to their legs because they had fractures, you know, because they had fractures from falls, from accidents and things like that. Because sometimes when people have car accidents, they can injure brain, spine, arms, legs, like could be a lot of other things. Like I had patients who had brain traumas, you know, and they had external fixations on their legs because they had broken bones there as well, you know. So if someone had really severe trauma and their cognitive state is not that great, they don't understand where they are, what they're doing and things like that, they may pull out the devices that they have. They can take out their trachees, they cannulas, you know, they may try to get up and things like that, or injure themselves. So for their own safety, until they recover, they may be placed on restraint order and be restrained for their arms or for their legs. The most important one would be arms, because this is what they use obviously to pull out the devices, you know, that sustain their life. But yeah, you as a nurse always check that your patient has a valid order for restraint, always renewed by the doctor. And if someone went for restraint, you have to inform their family members to let them know, because if they come and they find the relative is restrained and they've not been informed about it, that could be a big shock and stress for them, because sometimes people take restraint as something really bad, you know. They don't see it as a way to protect the patient from themselves, to sustain their life until they recover. So you have to make sure that the family members are informed of that. In this ward, you wouldn't be doing temperature to the patients through their mouth, so you wouldn't be doing it orally. The reason to that is that some of them can have sudden seizures that could be related to the pressure or swelling in their brain, and you never know if they have pressure or swelling in their brain until the seizures show up. Because sometimes if you have like a bleed in your brain, the symptoms might not appear right away, you know. So if you're doing, for example, a temp check on a patient, and you put the thermometer, which is look like a big metal stick, in their mouth, and the person started out of a sudden to have a seizure, what they do when they have seizure, they gringe their mouth, they jaws together, they close their teeth together. Can you imagine if the pressure that they do it with is quite strong? So if they do it on this metal thermometer thingy, you know, they can break their teeth, and you don't want that to happen. So in this ward, we always do temp under the armpit or anywhere else. You can use it to the forehead using a specific, you know, thermometer device and things like that, but never do it to the mouth. Okay, very important. Some of the patients may have neurovascular. I had one patient who had a DVT. Okay, so she was after that on neurovascular obs just for the legs. And you might find someone who would be having a spinal injury, so that person would be on a spinal obs, and you will have a specific spinal ob chart, which is very similar to neuro obs, because you have to check the strengths of the limbs. What else? If you have someone who has a BGL above 16, you have to check for ketones, notify the doctor, and obviously your body RN before this as well. If you have any PICC lines or normal cannulas, before administering medication through it, just make sure to flush before and after, very important as well. So anytime you're preparing your medication, always prepare a flush. If you have patients who come from different hospitals, okay, you will need to do on admission risk assessment and swabs, which is your nose swab and your rectum swab, and send them to the pathology. Okay, when you have a patient that comes from a different ward within the same hospital, like for example from PACU or from ICU, you will need to receive a handover on that patient by the nurse who brought it together with the wardie. While you're receiving handover, or just in the start of handover, connect all the devices to the patient and do the baseline of OBS plus neuro OBS, because if they send you a patient who is unstable in vital signs, you have all the rights to send that patient back and don't accept them in your ward, because you only accept stable patients. Okay, especially if someone is coming from PACU or from ICU. Check all the devices that's running, any IV devices, IDCs, you know, cannulas and all of that. Medications that's been given, especially for pain relief, PRNs and stuff like that. And then you as a nurse need to organize the patient's folder, which is your blue chart. Okay, so whatever the nurse is giving to you, like they will give you OBS chart, they will give you med chart, they will give you other observations and stuff, you will need to organize all of that into specific sections in a blue chart folder for that patient. So that was that. As for surgeries, you will have a lot of craniotomy and craniotomies. You can have decompressive crani. So that's pretty much when they take the bone skull off to relieve the pressure. If someone had a hemorrhage inside or a lesion or whatever, they can keep it off, which is your decompressive crani. So they take the bone off, they keep it off, they store it somewhere, put the skin back, close it, you know, just to let the brain swell if it's going to swell, you know, to pretty much under your skin, because if you have your bone back again, it will create a pressure, but if there is no bone, it will swell just to the skin. So you will find some of the people who had craniotomy, they won't have a bone plate. So this part, if it's been done on a frontal lobe or not, sometimes on temporal as well, you will find like it's more swelling. You will find that the head where there is no bone plate is more swollen, like it's big. And if you do removal of stitches or staplers, you may, like when you get closer to your patient, or if you are checking the dressing, you may have the veins pulsating under the skin. You can see the actual, like not the actual brain, but it looks like bumpy. It's quite interesting. It's not the best look in my opinion, but this is what people go through when they have really severe brain injuries. You as a nurse need to get ready for that, to see things like that, especially when you're taking stitches and staplers out, because you will be working really close to the surgical sites. Yeah, and if the person is mobilizing anywhere out of the bed, you need to put a helmet on the person who's been having craniotomy, because the bone plate is no longer there for some period of time. And if they have a fall, you can imagine you falling basically on your naked brain, just covered with the skin. I think it's called cranioplasty when they put the bone back again. Okay, so they store it somewhere and then they put it back again. What I wanted to tell you as well before I finish your video, yes, so I've been given in this hospital, I've been given a list of abbreviations. So this is pretty much when you have a handover sheet. For each patient, it will be written in abbreviation form what type of condition they had, you know, or name of the surgery and things like that. Like for example, DECRA, decompressive craniotomy in traumatic injury. So you need to know what that means. Or D or EDH, extradural hematoma, or CDH, subdural hematoma, or TBI, traumatic brain injury, you know, or TSAH, traumatic subarachnoid hemorrhage. So you won't see the whole name, you will only see TBA, TSH and things like that. So it took me probably 2 weeks until I started to get my head around it and trying to remember which abbreviation meant and things like that. So then finally on the 3rd week, one of my buddy RN nurses, she said to me, oh, you know what, actually we have this list, you know, somewhere like in the system files that I can print it for you, and you can see all of the abbreviations, what they mean, because I needed to literally like Google each one of them. And when you start your shift, you have so many things going on right away, so like you won't be able to Google it. But you need to know that things in the beginning, because you need to know what's going on with your patient. Why is he here? What does he have? You know, what type of surgery he had and things like that. So what I will do here, I will take a picture of this list, guys, and I'll put it for you in my Google Drive, and I'll give you a link. I do have some of the notes here already, but this was just notes for me. They're not written above the text, they're just written basically you know, like just on a empty side, so I don't think it will bother you too much. But if you want this list, if you ever go to this ward, will be really helpful, as it was helpful to me. So I think this is all what I wanted to say for this ward, about this ward. I generally liked it too much. It was very nice. I don't know, maybe I will even consider something like that for my grad program that I will be applying this July. So yeah, we will see how I go. But yeah, if you ever go to this ward, I think you guys will enjoy it, because this is very interesting ward. It's very different to any other surgical ward I've ever been to, and I've been to many. So yeah, I really enjoyed it. I wonder where I'm going to go on my internship, because I left in my next semester 2 more months of clinical rotations, which are going to be 2 months in a row of internship, because my uni runs it for 8 weeks straight. So I don't know whether I will be in one ward or in 2 different wards. Hopefully they will send me to a few different wards, so I could spend 2 months in different areas, because this is going to be my final ever placement, and after that I will be floating on my own once I get my license. So I want to get the most out of it, and hopefully maybe they'll send me to ED, because I had enough of surgical wards. I want to go to ED or cardio or IC. I want to go somewhere else, you know. So yeah, fingers crossed to that. If you have any questions regarding my experience in this ward, of something maybe that I didn't mention, leave it in the comment section below and I'll try to answer it. And yeah, I'll see you in my next videos. Bye.